Hello, I'm Dr. Ralph Powers, corresponding author for Soft Tissue Enhancement and Implant Placement following partial mandibulectomy due to squamous cell carcinoma. Oral squamous cell carcinoma is one of the most aggressive malignancies worldwide and accounts for 90% of all oral cancers. It is ranked as the sixth leading cause of cancer mortality worldwide. The most common sites of oral squamous cell carcinoma are the lateral ventral surface of the tongue, the floor of the mouth, and the buccal mucosa. Regardless of location, successful cancer therapy can affect the quantity and quality of soft tissue in areas where implants are planned, thus affecting the initial placement and the long-term success of the implants. Here we present a discussion of such a case. Our report begins with a 67-year-old female presenting to the University Hospital with leukoplakia at the retroincisal area of the floor of the mouth, as shown in Figure 1. A biopsy confirmed squamous cell carcinoma. Existing dentition was in poor condition with no posterior occlusion, as shown in Figure 2. After careful planning, the carcinoma was surgically removed with partial floor of mouth dissection. In addition, part of the vestibular portion of the mucosa was removed and a partial resection of the interforaminal portion of the anterior mandible was performed. That is, a partial mandibulectomy. See Figure 3. The surgery removed a wide area of soft tissues of the floor of the mouth and the anterior vestibular area, causing the union of the vestibular floor with the lower lip. This resulted in difficulties with speaking, swallowing, and movement of the lower lip. This union is well illustrated in Figure 4. The patient presented to the implant practice asking if it was possible to receive implant therapy to stabilize a removable denture. The patient has been in pain since cancer surgery and a dentulous with no denture to prevent tissue compression. Panoramic radiography as well as CT scans allowed for a plan to place 2 implants in the retroforaminal area and 2 in the area of partial mandibulectomy. Note the reduced alveolar bone in the area of partial mandibulectomy on the panoramic radiograph in Figure 5. The patient was prescribed antibiotics starting 2 days before surgery, continuing through 6 days post-op. In addition, non-steroidal anti-inflammatory drugs were started 4 days prior to surgery. Standard surgical procedure was followed and 2 6.5 millimeter long tapered implants were placed posterior to the foramina. In the anterior, 2 8 millimeter long implants were placed. You can see the implants in Figure 6. To overcome the total absence of the fornix due to the fusion of the lower lip to the floor of the mouth, an acellular dermal matrix, or ADM, was fashioned into a horseshoe shape to provide additional soft tissue mass. Autograft was not an option. The horseshoe was placed after careful dissection and every effort was made to provide good tension-free closure. The ADM horseshoe can be seen in Figure 7. Even with careful planning and surgical technique, it was difficult to avoid perfect tension-free flaps and provide good closure due to excessive scarring from the cancer surgery. Therefore, some areas were closed with high tension. Figure 8 shows the final sutured mucosal flaps. At post-op, instructions were given and no major problems were noted. Post-op instructions were for a soft diet, adequate oral hygiene, and use of chlorhexidine digluconate 0.2% rinse 3 times daily, along with chlorhexidine digluconate 0.5 gel applications. At post-op day 3, a wound dehiscence appeared and the ADM became exposed. This can be seen in Figure 9. The wound was disinfected with hydrogen peroxide and resutured. At post-op day 10, a large dehiscence was seen, as shown in figure 10. At this time, a combination amino acid hyaluronic acid gel, product name Aminogam, was added to stimulate mucosal healing. The next 4 pictures within figure 11 illustrate the sequence of healing. Top left is at post-op day 16. At this time, the dehiscence was visibly reduced. Top right is at post-op day 25 and shows continued healing. Lower left shows the formation of mucosal bridges at post-op day 33. And lower right shows complete closure of dehiscence with new visible soft tissue formation. Finally, figure 12 shows a stable wound bed at post-op day 60. Implants were exposed at 4 months postoperatively. Full-thickness biopsies were taken in the grafted areas for histological examination. See the top image in figure 13 for the location of the biopsies relative to the post-op panoramic radiograph. Locations are indicated by circles. The bottom image in figure 13 shows these circled biopsy locations relative to an intraoral photograph. A Toronto bridge was chosen for this patient. The 3 images in figure 14 show, going from top to bottom, a screw-retained mesostructure, a cemented superstructure, and the final clinical presentation. Hybrid prosthetics of this type are gaining in popularity, and this treatment best met the patient's needs. The histology in figure 15 shows a healthy incorporation of graft ADM tissue with host tissue and a surface partially covered by viable non-keratinized squamous epithelium. While keratinized tissue would have been preferred, studies suggest that non-keratinized peri-implant mucosa does not seem to predispose peri-implant disease. Keratinized tissue, on the other hand, seems to be desirable for hygiene and aesthetics, but is not necessary for implant success. It is important to remember that oral squamous cell carcinoma still has a high mortality rate, with 5-year survival at 57%. Those detected in the late stage of the disease have a 5-year survival of only 12%, with most dying within 30 months of detection. These statistics have remained unchanged for decades. Early detection is key. Clinicians must perform a careful examination of the oral structures, and patients should be encouraged to perform self-exams and make regular visits to their dental professional. The case I've discussed today shows how challenged patients' treatment may not always go to plan. It also shows how the newer therapeutics, biomaterials, and implant designs can provide solutions. Regardless, surgeon knowledge and skill is key in handling unanticipated sequelae. Therefore, it is hoped that more cases like this will appear in the scientific literature and that others can gain the knowledge and skills needed to provide evidence-based care following cancer surgery. I would like to thank the editors of the Journal of Oral Implantology for the opportunity to publish and present this case. Thank you for viewing this video.